We'll explore the synergies and differentiators of ACO REACH and MSSP, revealing the subtle nuances that set it apart. Buckle up as we hack into the benchmarks and navigate the labyrinth of risk adjustment strategies, all while exploring the red pill or blue pill decision for your organization. Is ACO REACH the chosen path?
Welcome everyone. We have Dr. Decker, who will be talking to us about the similarities and differences of ACO REACH program with other VBC programs. Welcome, Dr. Decker.
Thanks for having me today. Glad to be here.
Great. So there are many things which are similar, and there's some differences also between the two programs. Overall, I think ACO REACH is a nice path for many of the entities who have joined it. I think it's about 40% of the DCE entities who converted into ACO REACH. Several of them did not. Any background on, you want to educate us on that?
Sure. I agree. I think that ACO REACH really provides an opportunity for our physicians to do their best work and to be reimbursed. And so that migration from DCE to ACO REACH had a few changes to it. One being who needed to be a part of the board. And so it used to be for the DCE agencies that converted, they had to go from 25 to 75% physician representation as part of their board. And so again, making sure that physician voice is strengthened. And then also too, for the new entrants to ACO REACH, it was a little bit different. For DCE, I know that CMS talked a lot about compliance, making sure that documentation was appropriate, making sure to put in, especially with the new entrants and going forward, to put in governors, if you will, to ensure that they were getting the best, right, of all the different models, taking the best things from what we know of MSSP, taking the best things that we know from the traditional Medicare Advantage HCC model, and coming together to come up with this new model. And so we had the, like I said, greater representation from physicians, but also too the way in which risk scores were calculated. And so as opposed to it being retrospective, like you would have in an MA program, the risk score calculation for the traditional ACO REACH, and this isn't taking into account the REACH populations that are the chronic kidney disease, or the extremely sick patients, those special populations, but just looking at a typical Medicare membership, the RAF score is the risk scores for those patients are calculated prospectively. And so what that means is they're looking back at the year prior and using that to project what the expenses will be for that traditional patient population. Not as long as you would find in Medicare Advantage, but not as short as you would find in some of those concurrent models. And so the thinking there was that you would have something that would be more in line with truly what the patient would experience would be related to cost. Some of the things I think with ACO REACH that's a benefit over the former plans, again, is bringing up that revenue to be more true to what the patient might incur within a given year.
So we are also moving from V24 to version 28, and that will also impact how providers need to really be careful about the documentation. Would you like to add something there?
Sure. So ACO REACH, as far as we know now, will continue on the 24 model, but I would definitely expect us to transition to 28 in the very near future. There's still conditions, right, that are true. So, the vascular disease, the differentiation between diabetes, all these things still exist in V24 under the ACO REACH model. We can expect that, though. I truly believe that we'll see that transition to 28 in the near future. And the recommendation would be the same, right? Would be make sure that you're documenting completely, especially a lot of times I think physicians worry in whatever model you're in that they have to write down everything, right? It's the alpha and the omega of every condition that could be possibly true for that patient. And that's not necessarily so. Really focus on those conditions that you're treating. If the patient has multiple conditions, there is a factor or a coefficient added for condition count, just like there is in Medicare Advantage. But really focusing on in that clinical note, what's the diagnosis? So what is the condition that that patient has? And then evidence that you're treating that. You can't put something in that medical record, that doesn't have some type of indication of a treatment plan. So making sure that you're capturing that as well. But we know that just in the, in the information that's been given to us by OIG and by CMS, is that, again, making sure that you're showing evidence. If you indicate that a patient has, say, diabetes with complications, we should see that in the medical record, right? So that should be carried throughout, and documenting it once within the year, not going to go a long way in indicating that the patient has this condition. There should be evidence throughout the life of that record, demonstrating that that patient does have that condition.
Absolutely. And I think I was reading the CMS intro to version 28, and they did mention that they want providers to look at holistically at the entire patient and not just conditions, because traditionally some folks have just looked at capturing these conditions and made it more like a business, but they really want the providers to look at the patient and take care of them. So I think this is a good change, and we need to be thinking holistically. After all, it's the patient in the center. So I feel that's a good change, but it need some change in our focus, in our thinking, and in our technical capabilities, because now it's not just capturing the conditions. Now we really need to manage the population, take the right actions at the right time, do the right and accurate documentation. So I think the bar has been elevated with this change.
Absolutely agree. I think of it as almost like a three-legged stool, right? And if you don't have all three legs, it's going to fall apart. And a lot of times we focus on, and I think, to the fault of the industry, we focus on a few components. You can't do that. Human care is so complex. So to focus on just a couple of different pieces is not enough, right? It's going to make that stool, to continue with that analogy, it's going to make that stool unstable. And so really thinking about, let's capture the conditions of the patient, right? So this is the important thing of ACO REACH. And I know that a lot of our groups with the best of intentions entered ACO REACH, but not understanding, right, the fundamentals of that stool and the three legs that were needed, are now finding themselves in a different position, right, than maybe what they expected. And so it's one thing to focus on capturing risk and capturing the chronicity of a patient, right? So capturing all their conditions and documenting that and making sure that it gets submitted. That's a big piece of this. And you don't have the windows that you had with Medicare Advantage, or that you have with Medicare Advantage. But then also too, focusing on the quality measures, making sure, so all of those things that we recommend in Medicare Advantage, true for ACO REACH, right? Making sure you may not be weighted on all the quality measures, but they're just as important. And so making sure that patients are getting the preventative care that we know that they need, making sure that they're getting the vaccinations that they need, making sure that they're taking the medications that you're prescribing to them. And all these things are really important because they're going to make sure that those patients stay healthy, right? Or at least stay within the traditional trajectory that we would expect on a well-managed condition, right? Or in someone's health, getting mammography early, obviously, or getting the colorectal cancer screening early, diagnosing early, there's more opportunities to apply a greater variety, right, of treatments, as opposed to someone who comes in and is stage 4 because they've just missed getting those important preventative visits. The third leg that's really important is around total cost of care. And so managing cost. And I was looking actually just this morning on the estimated cost around ACO REACH, and in the initial papers, CMS is reporting that there's been significant savings, but they did mention, and I thought that this was an important footnote, about making sure that they had complete claims history. And I think that that's a very important component because it will truly indicate whether or not there were any savings, right? They need to see that data. The other thing, though, that I think that it's important is, managing total cost of care isn't making sure that patients don't go to the doctor, right? It's making sure that they go to the doctor, and to your point, at the right time, at the right place, right? They're coming to your office during the day as opposed to showing up at the emergency room. And so those are the important components that we really need to pay attention to, because you can do a great job at capturing risk. And there are some conditions built into ACO REACH that it isn't the same like it is in Medicare Advantage. It's really important to manage those quality conditions to ensure that what comes out, right, what's of consequence is that total cost of care. And so again, you're not overspending and you're not disrupting, right? You have a nice solid foundation. You have a good stool to sit on that won't get knocked out from under you.
Absolutely. And one of the technical things that I found interesting is, as we know, there are two tracks for risk sharing arrangements. One is global option and one is the professional option. And what was exciting to me was that in professional option, there is no MSR. So you actually get the savings back on the first dollar. So I thought that was exciting, and that can be an incentive for new entrants to go and play with this low risk option and get the money back or shared savings of 50% on the first dollar. Obviously, the global option, which is full risk, full reward, it has a 3% cap. So there's a difference there.
I think you bring up a really good point. If you look at, I think last I looked, the count, it's amazing. We went from 15 entrants to 80 some odd entrants. And within 1 year, almost doubled that. So I think we're at 132 for 2023. Mm-hmm. And what's interesting is most of them did choose global risk.
Yes.
Yes.
I did see that. And I was very surprised, Dr. Decker. What is your take on that? So this slide just goes into what is MSR, MLR, and that, you have to really achieve that benchmark plus the 3%, which is true for global risk today. In this example, is at 2%. So just shows that and clarifies to our audience what actually MSR, MLR is. Dr. Decker, I would like to ask you, I was a little bit surprised on a lot of entrants using global. Is it because they have experience with DCE? Some of the names seem familiar. We were comparing the list. Or is it something else which is going on?
I think a lot of folks chose it. There's a lot of groups, right, that have entered in. And I know there's a lot of partnerships out there with health plans, with different vendors and different offerings. And I know that a lot of folks saw this as a very exciting time, right? An exciting opportunity to get involved in value-based care contracting. I think the challenge is, though, again, is that recognizing cost of care and how significant it is. And it's not something that is managed well. And going back to that whole point of, that you made around, whole person care, again, it's managing risk, it's managing quality, it's managing total cost of care. I'm trying to think of, to use another analogy, the forest for the trees, but you have to see the forest. You have to see the totality of it. And a lot of groups, I think, entered into that global risk arrangement, not realizing how difficult managing total cost of care is, which really requires you to be on point with your submissions and with your data capture. And if you're not, right, it can make it very challenging. And so while a lot of groups did enter into global risk, I think, there's still opportunities If you've gotten into a place where you feel like you need to course correct, and that's really looking at tools that can help you manage that data, bring that information together, and then working on some comprehensive cost control measures, if you will. There's lots of different programs out there looking at what your particular needs are and addressing those. But I agree with you. I think professional risk, if I were a new entrant, or didn't have a lot of infrastructure, and you have to be honest with yourself, you cannot sit there and say, well, I know what I'm doing. If you do, right, you may find yourself at that tough end, if you will, of experiencing global risk. And so I would agree with you. I think that if I were new and trying to figure out what exactly was needed related to REACH, I would probably choose the more conservative path and go with professional risk until I felt like I had done enough study as to what my infrastructure was and is and how I was performing before I would take on global risk.
Thank you, Dr. Decker. But one of the groups that you are associated with and you have some experience with, they did not go for for the professional track. They went for the global track. We are not familiar with their background and how it's what's their experience been. Is it possible to share just at a very high level some information?
Absolutely. So I work with a lot of medical groups, actually, and
Okay.
I have a few that have opted to take global risk. One that took professional risk, interestingly enough, because that's the thing, that my experience across my clients has been very similar to what we see in the sign up, right, with CMS, is that the majority elected global risk. And some of the things that we're finding is submissions. So many components to that, both that are meaningful for professional as well as global risk. So making sure that your EMRs are set up appropriately, submitting for billing and E&M coding, procedural coding, totally different, right? Totally different needs when it really comes to quality and risk and being able to capture that information. So really taking a look at, and for my Medicare Advantage folks, they'll be familiar with these challenges too. Taking a look at those EMRs, what's the quality of data that's coming in, that's being captured? How is it being aggregated? And then, using that data, making sure that it gets submitted and really digging in deep. It's not enough just to glaze across the surface and say, oh, I have a file here and it must be good. Really look deeply into what that file is telling you, because I can tell you, there's a lot of times where data gets misaligned, put in the wrong places, or submissions. So here you bring up an interesting point, because like I said, I was reading this morning just around CMS reporting all these great savings. And I'm like, we used to see that too. And they talk about seasonality, but one of the things that I think that they're not taking into account is the submission cycle and claim submissions. If you're holding on to data and you're not submitting timely, and you're not then submitting that data timely to CMS, right? What it does is it causes an imbalance, and it really interrupts or causes fluctuations in your revenue integrity. And so you want to make sure that you're submitting timely and on a regular basis. And again, like I said, making sure that that data is complete. And then you get return files. What's been counted, right, at CMS as far as for what risk scores and things like that have been calculated on your patients. And so making sure to get that data and do that check, right? How does that match with what you knew that you had in your system and what you submitted? And if it's not matching, don't wait. Get intervention. Again, there's lots of tools out there that can be put to use to help you get that calibration that is so important in this, in these programs.
Great. Thank you, Mara, for sharing with us the global and the professional option risk slides. I think we covered that. Next slide, please. This goes into the benchmark. The benchmark is a little bit different from other ACO REACH, from other ACOs such as the MSSP ACO. It just uses the MA rate book rather than fee for service. I think the years that they took into account were the 2017, 18, 19 for the benchmark, for the financial benchmarking. And the new thing is the SDOH and the ADI data, the area deprivation index, and the dual status, which also impacts the benchmark. This is new, Shannon, about SDOH. Any comments on that?
I think it's so important. Everything that we've been saying thus far, right? We need to look at what are the things that can possibly impact someone's health. And we know that social determinants is one. And so if you live in an area that is impoverished, right, as a food desert, or challenged by health literacy, don't know how to take your medication, right? Don't maybe use the right site of care for whatever ails you. All of these things influence how we take up our medical care, right? And so looking at the, I always think of, and definitely a proponent of the biopsychosocial model, that health isn't just about biology, right? We know so much more today about how psychological and social factors influence, again, how we take up our healthcare. And so paying attention to those, giving them a value, very important. And will go a long way in improving the care of patients. Can't say enough about how important this is. And I know I've shared with you in the past, I had the good fortune to be part of a group that really talked about the importance of bringing SDOH into our risk models. And there was a lot of discussion around how do we account for social determinants of health in the model, particularly around not providing more and more money, right, for reimbursement for our beneficiaries. And so the thinking was that, there were opportunities to ascribe a value to the social determinants and build that into the model in that way. And so a lot of the changes that you're seeing around risk adjustment, about how we're thinking about things, between morphing from what we see with ACA versus Medicare Advantage and now REACH, are a result of, that practice. And I kind of think of it like a pilot. We're learning from the work that we've been doing and then trying to pull together the important pieces. And so, that's why I think SDOH is so important, and so happy to see that now recognized in the model and being attended to.
So we are talking about HEBA, the Health Equity Benchmark Adjustment, which is a combination of ADI and also the dual status of the patient. And if the patient belongs to the top 10 percentile, like the 90th percentile or above, then they get $30 extra. So I think this is important. There's now some money tied to it, some incentive for these providers. Often these providers don't even join the ACO. So I think this is a good change, and this is the first of its kind. So I think providers will welcome this change very much.
I would agree. And, there were a lot of developments, even just the other week, around getting reimbursed for doing SDOH screenings.
Yes.
Widening who could do them, right? The thing with SDOH is that at least last I knew, it could be reported by really anyone on the care team, could even be self-reported. But then also too, physicians and in their offices can be doing these screenings. And that is one of the key parts of, and I think, just like when we were talking about ACO REACH being challenging about whether or not you chose professional or global risk, equally challenging is the collecting of that data for the Health Equity Index. And so, there is that requirement that you are reporting and acquiring information related to SDOH on your patients, and then developing plans. And I know that that was something that escaped a lot of people. There wasn't a lot to go off of, but how are you identifying your most at-risk patients and then implementing plans to offset, right, or to mitigate any disparity that they may have related to, you know, their, you know, where they are, where their demographics are.
I think you're talking about the proposed physician fee schedule for 2024, which have introduced certain codes for SDOH and social determinants of health assessments. So the CMS seems very serious. So it's not just the VBC part where we are seeing these changes, but it's also in the physician fee schedule. And when something enters a physician fee schedules, we really take it seriously because this is really a global change, and they have made it open, and they are proposing, as you're saying, it's not just the providers, but the clinical staff, just like CCM, the clinical staff can also do these assessments. So I think these are very welcome changes, which we are going to see. Let's see if they're confirmed later in the year.
And, you know, no, I agree. And I think one of the other important points that you know, one of the other important things that you pointed out is that we are seeing, right, these changes. So if you're just reading things about ACO REACH, or if you're just interested in Medicare Advantage, I think that's really a short-sighted approach. You really need to pay attention to all the different changes that are going on across the, you know, across the industry. It really should be viewed as a horizon, and what is, you know, what is the image that comes into view or comes into focus. And so seeing changes, say, to the fee schedule, right, has that ripple effect or has that impact. We can definitely see the connection to the other models that are out there.
Absolutely. And we have a slide here which shows us how this benchmark is calculated for ACO REACH. How do the geographical factors come in? Is the MA rate book which is going to be used? What are the baseline years? And how it's adjusted at the end with the quality withhold. Quality is always there, part of the benchmark, whether it's MSSP or whether it's ACO REACH. So that part has not changed. Next slide. That's our conclusion. So thank you, Dr. Decker. Anything you want to add for our providers? Any take-home message, how to do their ACO REACH programs, how to optimize them?
There are a couple of other things that I would pay attention to. One is recognize, as it relates to HCC risk, that there is a cap. And so there's a 3% positive or minus effect year over year on your risk score. And so you're only allowed to grow so much. And so recognizing that you have that, as well as coding intensity being applied, that's why it's so important to really make sure that your documentation is comprehensive. It's not like you can go back and then add things on later, right? I mean, there's opportunities to submit data, but going back to what we were saying around having that complete record, showing and demonstrating that you're actually caring for that condition, and then making sure that your submissions are whole is going to be so important. You don't have the value or the benefit of time, right? And so really making sure that you're submitting timely so that your quarterly payments that you're getting are more in line with the care that you're sharing. I think one of the other important things to note is knowing who your membership is. So there is a difference in whether or not a patient is claims aligned versus being voluntarily aligned. And so some of the nuances are whether or not those caps apply. They don't apply on patients that are voluntarily aligned to you. If it's shown later, especially our groups that went from DCE over into REACH, if it's shown later that those patients truly should be claims aligned and they're looking back, right, within that 12-month period, should they be attributed to you, you'll lose the value of that patient being voluntarily aligned. But if they are truly voluntarily aligned, and I think that our newer entrants really have an opportunity here, see those patients, make sure that their information is submitted. And you'll get the value of providing that full record that is appropriate for that patient. And so lots of little things I think that you can hone in on. But of course, finding people in the industry that are knowledgeable, that can help you, right? Determine what levers to push on, having tools like I know the tool that Persivia has are all important in being successful. It's not easy, it's complex. And so it's not something that I would go alone by any means.
Great. Thank you so much, Dr. Decker, for joining us today. Thank you, everyone.